Good evening, everybody, and thank you for coming to this Association of Anaesthetists webinar entitled I'm Only an Anaesthetist, What Does Climate Change Have to Do with Me? My name is Frank Swinton. I'm a consultant anaesthetist up in Airedale Hospital in West Yorkshire, just north of Leeds and Bradford. I'm also the climate change lead for West Yorkshire ICS. And I also sit on the Environment Committee of the Association of Anaesthetists. I've got a few notes for you, a few comments for you, and then we'll get going with our first speaker. As I said, thanks for attending. There are about 350 people booked to come this evening. They won't all come, but everybody will get a recording in the next day or two. Because there are so many delegates, we're not going to switch your microphones on today. So if you have questions for any of the speakers, please use the question option, which is on your control panel, usually on the right-hand side of your screen. Please send your questions. We've deliberately allowed lots and lots of time for Q&A later on, so that you, the listeners, can get as much as possible out of this session. If you choose to, you can use the orange arrow on the top right of your control panel to reduce the size of that control panel, which will enable you to see the rest of the screen and the slides a little bit better. And the speakers will be displaying their screens. So if you click off and can no longer see the webinar, if you get lost, try clicking the blue or orange flower icon, which should be on your taskbar. And when we switch between speakers, there'll be a slight pause of a few seconds as they check that their screen is showing and that the sound's working, that sort of stuff. So there will be a little interruption between speakers. And of course, please be aware that this is an educational and scientific meeting, and we would expect anyone reporting it outside to do so responsibly, accurately, and to provide the context of any statements that are used. So I'm really excited to be hosting this webinar this evening. We've got three fantastic speakers, all of whom have taken time out of their training posts or out of their careers to dedicate a year of their lives to working on sustainable healthcare and sustainable anaesthesia. So a wealth of experience. And when we were putting this webinar together, I was also really keen to hear about people that are in the first half of their career rather than in the second half of their career, because I think that they have a viewpoint and a voice which is not heard quite so frequently. And I'm very keen to hear about the world as they see it. And without further ado, I'm going to hand over to Veena Agarwal, who is going to talk about why clinicians should get involved in the climate and ecological emergency. Veena is a GP trainee in Kingston in southwest London, having returned to clinical practice from a fellowship at NHS England. She's also the vice chair of the Royal College of General Practitioners Sustainability Working Group and set up a Greener Practice Trainee Forum for GP trainees and Kingston Hospital Green Group. So Veena, thank you very much for coming this evening. Over to you. Just before you start, Veena, I should say we're going to, Veena has to leave early this evening. So if anybody has questions for Veena, please put them in the question box during Veena's talk. Then we'll have questions from Veena. Then we'll have the other two speakers and final questions at the end. Thanks, Veena. Over to you.
Great, thank you so much. And just to check, you can see and hear me and see my full screen, okay? Presumably.
Yes, we can.
Oh, yeah, okay, perfect. So thanks so much for the introduction, and thank you all very much for having me and for giving up the evening to talk about climate today. So as Dr. Swinton said, I'm Veena Agarwal. I'm a GP, final year GP trainee in southwest London, and I've been involved with climate stuff now really for about sort of 3.5 years. And so I'm just going to, I'm not an anaesthetist, so I'm not going to talk about the anaesthetic side in particular today because the other speakers will cover that. But I'm just going to give a general overview of why clinicians should be involved in the climate and ecological emergency. So I just want to start off with how I got here. I haven't always been an environmentalist. I haven't always been thinking about climate change or acting in a very environmentally friendly way. And the first time it really came up for me was when I lived in New Zealand in my sort of F4 year. So January 2020, I went on a road trip to northern New Zealand. I was sort of living and working there at the time, and it was the height of summer, and the sky turned smoky, and I could taste it. I could feel something wasn't right, and it wasn't a local fire. The whole horizon was full of smoke, and it was from the Australian bushfires. It was over 2,000 kilometres away over the sea. And I think for me that was a real turning point, because I hadn't really felt the effects of climate change at any point before that, and it really hit home how big a problem this was. And I put that picture there because it shows what the sky was like, and the sun, you couldn't even see it. It was quite scary. So I came home, COVID was happening, and I also started to connect environmental issues with pandemics. So reading articles about how when we interact with nature in a certain way, with animals, we can cause zoonotic diseases to spread between them and to us as well. So I started making all these connections, environmental issues that I hadn't really thought about before. Then I started my first year of GP training in 2020, and just started thinking about some small projects in the hospital I could do. I didn't really know where to start, but I started asking a few people, and a little project there. Then I saw the advertisement of the Sustainability Fellowship, the first year of it, NHS England, where they were looking for people to join Greener NHS, which is the team at NHS England who are doing the national strategy and policies about NHS sustainability. So I applied and was lucky to get a fellowship there. So I spent a year as a primary care fellow there, really looking at the primary care environmental footprint, and mainly focused on inhalers. And I came back to training just over a year ago, did my ST2 year, and now I'm doing ST3. And now I'm involved with some things, and I feel like my leadership skills on climate change really improved during that year, and I became a lot more confident at approaching senior people in hospitals, for example. So I've been doing quite a lot of different initiatives, as you mentioned earlier. So that's me and how I got into it. So just briefly, what's the situation with climate change? Now, you're all here because you're worried about it, so I'm not going to try and scare you, but we know it's the biggest health threat facing humanity, and the WHO have been very clear on that. We're about 1.2 degrees, and that doesn't sound like that much, really, if it was just your sort of everyday temperatures, but it causes increase in energy in the atmosphere, and that is what causes these floods, the heat waves, and the extreme weather events that we're seeing. And we know that we have to limit temperatures to 1.5, and that isn't because that is a cutoff for where it's safe. It's because when we get above that, we may start to reach tipping points where things become more and more irreversible, because the world and the environment is in a homeostasis, just a bit like our physiology, as you anaesthetists are very good at. So you know that when things get beyond a certain point, then those cycles can't come back to where they were. So the Earth is a bit like that too. And we know what we need to do, because amongst other things, the International Energy Agency and the UN have said we can't have any oil and gas licenses. So we need to really go to a greener economy ASAP. And I just wanted to bring some hope into this, because it's all very depressing on the news and you just think, oh God, this is a disaster. But I mean, the bad things that IPCC, the International Intergovernmental Panel on Climate Change, says is that climate change is already harming people's health and well-being everywhere. It's not a future problem, it's a now problem. And we do need to reduce our fossil fuel use now and start doing that drastically. But the positive things I don't think get reflected on in the news enough. So climate solutions benefit the health and the economy as well as the environment. So they're a triple win. So anyone who says it's too expensive, it's not true, because it's good for the economy. And also climate solutions are possible with the knowledge and technology we have available now. So this is why I get out of bed in the morning to do climate stuff. This is what keeps me going, because I know that we can do it. And this slide is a little bit political, but I think it's really important for us to understand as doctors, because we can't just be mopping up and firefighting at the end and treating people when they get sick. We have to understand what makes people sick and try and actually campaign for and tackle that as well. And this is what we call the commercial determinants of health, when we look at the tactics from different industries and how they impact on the health of our patients. So the fossil fuel, the tobacco, the junk food, the pharmaceutical industry, all of the industries have very similar tactics. They sow doubt in the media, they spend a lot on PR, they do run their own research studies to try and change what the evidence shows. They do marketing to change political norms. And they want to make money for their shareholders. That is their #1 priority. It is not public health. And all of them have their priorities are actually at odds with public health. And an example is that the fossil fuel industry has known about the impacts of the climate crisis for 70 odd years, if not more, and they have been covering it up and sowing the seeds of doubt in the media. So BP made up the term carbon footprint to make people think it was all about them and their own behaviour, and actually letting them off the hook themselves. And I could go more and more into this, into the lobbying of politicians and the different donations that people are giving with oil and gas licenses and things. But anyway, I'm going to focus more on healthcare, but it's just to say that we have to think about commercial determinants of health and what's making our patients sick. So climate change impacts on human health. And there are lots of different ways that it does this. And I think you'll probably be aware of quite a lot of them because we see in the news all the time about the extreme weather events. And in the UK, air pollution is one of the most common ways that it impacts on our health. And that doesn't just impact on lung diseases, which we know a lot about, but actually cardiovascular diseases, so heart attacks, strokes, and longer term impacts as well. Air pollution has a very high correlation with those. We're seeing increases in respiratory, for example, allergies and asthma due to the increasing temperature, and vectors are spreading. So we're seeing an increase in Lyme disease in this country because of the increased weather, and those vectors are able to spread more. So that's just a variety of ways in which the climate crisis impacts on health. So as doctors, we should know about this. And it's not just a issue about carbon, but it's a social justice issue. So we know that both worldwide and also in this country, the poorest and the most marginalised people are hit the hardest, but they are actually responsible for the least amount of carbon emissions. So you can see on this green graph here that the poorest 50% of people are only responsible for 10% of emissions that are related to consumption, whereas the richest 10% are responsible for about half of them. So there's a huge disparity between who's making the emissions and who is being affected by them. And it's a women's rights issue. Women are more affected. It's an Indigenous rights issue, and children are more affected as well. So they're some of our most vulnerable groups in society. And I want to mention this little girl. Some of you may have heard about her, Ella Adukisi Deborah, and she died at the age of 9 from an asthma attack in 2013. In the last 3 years of her life, she had 27 admissions to hospital with asthma. And the reason her case is so spoken about and significant is because she lived 25 metres from the South Circular in Lewisham. It's a very, very polluted area. And her mum, a little bit of time after she died, I think a few years, her mum was contacted by someone and said, have you thought about pollution? And they mapped out the dates that Ella was admitted to hospital and what the levels of pollution were on those days, found a correlation and made a campaign to the coroner's court to put it on her death certificate. And after a long campaign, she was successful. And Rosamond, who's there at the bottom, she says very clearly that no clinicians thought about air pollution relating to Ella's health. And if she'd known, she could have done something about it. So this is why it's really important as clinicians that we know. I do a lot of teaching for different GP training programs, and I always ask them, do you talk to patients about air pollution? And it seems that actually amongst clinicians, the knowledge of this is quite low, because people don't think there's time, they don't think there's relevant to talk to patients, they don't think there's anything patients can do about it. But what I really want you to know is that patients can do stuff about it. They can avoid indoor and outdoor air pollution, and maybe not 100% of it, but they can avoid quite a lot. So in terms of outdoor air pollution, they can walk on side roads, take different routes. They should know that they get exposed to more pollution inside their car often, especially in peak time, than when they're using active travel, and trying to avoid peak time as well possible. Easy steps, but you can reduce your exposure by quite a bit. And even things like walking on the side of the curb a bit further away from the cars can make a big difference. And then indoor air pollution. We spend about 90% of our time indoors. And actually there's even a nice guideline on indoor air pollution. And I say to patients, even if it's just one sentence, when I see anyone who might be affected, my advice is to avoid burning anything in the home. So fires, wood burners, candles, incense, avoid any products which are very chemically or fragrance, and gas stoves can cause indoor air pollution. So just make sure when you're cooking with a gas stove, you have the window open during or at least after for a while, just to ventilate the house. Such easy advice to give patients, and it can reduce their exposure by quite a lot. And the other thing is they deserve to know what's affecting their health. And if they know, then they can campaign, they can write to their council, MPs, whoever, and actually become active in this space. So I've got this slide on why doctors should be involved in the climate crisis, because I think a lot of people think, well, I'm already saving lives, I'm too busy, you know, I've got my place in heaven now, so this isn't my job. Someone else like Greta Thunberg, they can do that, that can be their job, and you know, I've already got other better things to do. But I would argue that this is not the case, because the NHS makes up 5% of the UK's carbon emissions. And we have a duty to do no harm as clinicians. So we really need to be involved in this, not in only making our own care more sustainable, but in campaigning about the climate crisis and its effect on people. And also because we are very trusted figures in society. So when we speak out, people listen. And I've got a little slide which shows where we are in, it's called the Veracity Index. And it shows, they asked people just in the public to show, to say which professions they trust. And so nurses and engineers do beat us, but we still come up third, so we're 85%. It was high a few years back, I'm not sure why we've gone down, but anyway, 85% of the population actually trust doctors. So when we talk about this, people are going to go, oh my God, I need to pay attention. Whereas if you look down the bottom, if a politician speaks about it, only 12% of people trust them. So it's important that actually we use our voices wisely and raise the profile of this issue. Simon Stevens and Amanda Pritchard says a similar thing. Climate change is the most profound long-term threat to the health of the nation. So it is an NHS priority. And Climate Change Act has actually got the healthcare system in the law, so that we have a duty to respond to the targets which are entrenched in law, because we're the largest public sector emitter. And the GMC has got protect and promote the health of patients and the public. So that is very important. And the GMC, in terms of the new outcomes for graduates, they've said that we should be able to apply the principles and knowledge and methods of sustainable healthcare to medical practice. So it is there in all of our different constitutions. So where do the emissions come from in the NHS? Well, they come from a huge number of sources, and I'll show you some of them more on the next slide. If you're interested in looking, I would really recommend having a look at this document, which is on the Greener NHS website, and it shows how we can get to net zero, and it's got it all laid out. The Greener NHS team have worked out the different work streams and the different methods that we can get to it. And we've got targets. So our target is to get to net zero of our direct emissions by 2040 and our indirect emissions by 2045. So it might seem like a long time away, but it's a huge piece of work. So we've just got to do everything that we can. And this is this pie chart is a breakdown of the emissions. So clinicians are so important because the clinical side is massive. We've got medicines at 20%, our equipment, oral supply chain, which is basically a lot of the stuff that we use every day. And then look, anaesthetic gas and metered dose inhalers are 5%. So the anaesthetic gases are about 2% within that. And then all of the other things are massively affected by the clinical side. And not only do we have to reduce all of those slices of the pie chart, but when we think about principles of sustainable healthcare, this was written by the Centre for Sustainable Healthcare and is a really useful way of I see this as a lens by which we view healthcare, not an extra project to do on the side, but a way of doing things. So if we can prevent patients from needing to come to us, that's the greenest thing. Empower them to take a role in managing their own health, and that might be chronic diseases, or it might be minor illnesses, or whatever there's so many things that we can help to empower them with. Lean service delivery just means making sure things are streamlined, reducing waste, making sure we're not duplicating, and using lower carbon alternatives, which could be a remote consultation, or it could be using a lower carbon inhaler or anaesthetic gases. So this is a really great principle of how to think about how we manage care on a day-to-day basis or design our services, for example. And we know that sustainable healthcare is good because it's just good healthcare. So it actually is good for the environment, it's good for health, and also often it saves us a lot of money, especially if we're reducing waste within the system as well. So in terms of wider actions, I could talk about this forever. So we have to do things in what I call the 3 Ps: your personal, professional, and political. And none of us can be perfect, and we can't do everything, but we can look at our own lifestyles and what we're eating, how we're traveling, who we bank with. All of these different things can work out how we as humans are more sustainable within our kind of remit. Professional we talked about, and then political. So as I've kind of alluded to earlier, I think we really have to get political about this, and I'm not ashamed of saying that, because I know not everyone likes us to talk about politics and health, but only 10% of health outcomes are related to healthcare system. 90% of them are related to our environment, or housing, or our income, or everything else that's outside of the healthcare system. So as doctors, we need to think outside of our own workplaces and actually try and advocate for this biggest health crisis. So that could be anything from talking to your colleagues, talking to friends and family. Everyone's worried about this, but it's basically an elephant in the room, because everyone's scared and they think it's depressing. But just trying to open those conversations up a little bit, find out how other people feel about it. Writing to your MP if there's an election coming up, making sure they know that you're concerned. Writing to anyone, and there's lots of environmental organisations or campaign groups. And I haven't put the logos on, but there's MedAct, there's Health for Extinction Rebellion, there's Ecomedics, there's some anaesthetist networks as well. So just join something and see what's going on. Have we got time for a 2-minute video? I don't know how long have we got? Okay, I'm just gonna play it.
My name is Richard Borton and I'm editor of The Lancet. The climate emergency that we're facing today is the most important existential crisis facing the human species. And since medicine is all about protecting and strengthening the human species, it should be absolutely foundational to the practice of what we do every single day. The GMC publishes an extremely important document which guides all health professionals' duties of a doctor. The duties of a doctor are first and foremost to an individual patient or the public that they serve. The climate crisis is one of the most, I would say, the most existential crisis facing our communities in the world.
Oh, sorry, I think I pressed my space bar. Oh, let me go back to where we were.
My name is GMC publishes an extremely important document which guides all health professionals' duties of a doctor. The duties of a doctor are first and foremost to an individual patient or the public that they serve. The climate crisis is one of the most, I would say, the most existential crisis facing our communities in the world today. Doctors and all health professionals have a responsibility and obligation to engage in all kinds of non-violent social protest to address the climate emergency. That is the duty of a doctor. The GMC, based on its own documentation, should be fully supportive of all health professionals who engage in that kind of non-violent social protest. My thoughts about the doctors who've been arrested during the Extinction Rebellion protests are thoughts of extreme humility. I hope that those who work in the medical profession not just recognize the contribution that they have made personally, but make sure that they are protected from anybody who might seek to damage or harm their future careers in medicine. We're the only species that exists that's created this incredible superstructure of a health system. Fundamentally, human beings care about each other. We wouldn't have built health systems if we didn't care about each other. We wouldn't have nurses, we wouldn't have doctors or any other health professionals. We wouldn't have created clinics or hospitals unless we fundamentally loved one another. Surely there's not only great hope, but also great encouragement for health professionals and their organizations and other groups in society to work together, to cooperate together to solve these problems that we face collectively. If every single person who's a health professional, just did one thing every single week, we'd be having millions of people committing themselves, acting in a way that when you multiply that up over time, could be absolutely transformational for the politics of our country. That should be inspiring hope amongst all of us that we really can achieve social change. And if you look at the history of social activism and the history of social change, that is what has done it. The brave acts, sometimes the small brave acts of a large number of people have made the difference. And that's our task, our responsibility today in the 21st century. My name is...
So yeah, that's Richard Horton, and I find that really powerful because it's so positive, and I totally agree. And if we look back at all the social protests that have happened, whether it's the suffragettes, whether it's the American Civil Rights Movement or Black Lives Matter or whatever, there are always going to be people who criticize, but actually, you know, this is what is really, really important. So there's this group, Health for Extinction Rebellion. I've done a few things with this group, and it's really, really lovely group of people, really positive. Most of the time, so most people do not participate in arrestable actions, but there's a small subgroup who do. If you don't want to get arrested, then you still can take part in lots of things. And there's been protests outside the Treasury, you can see here, ones with shoes for the number of people who've died from air pollution, corpse actions, all sorts of things. And it gets really positive media coverage, because a lot of the criticism is normally things like, oh, these people need to get a job, or you know, but you can't say that when we're all in scrubs, knowing that we are healthcare professionals. So it's a really powerful message, and I think you do get a lot of members of the public coming to talk to you and asking what's going on, and it's a really good way of getting the message out there. So this is just one final quote, which I find really powerful as well. I'll just let you read that for a second. So we are alive at a critical moment, at a turning point, and there's a lot we can do. I think it feels quite overwhelming, like as one person, to think, oh God, I'm only one person and there's only so much I can do. But actually, imagine if all of us were having these conversations and doing one little thing every week or every month, just changing something in our workplaces or in our own lives, or writing a letter. The amount of impact we can have as a collective is massive. So this is just my summary. So the climate crisis is a health crisis. As clinicians, we have a lot of power to make change. And don't do it alone. You know, talk to people, find people who you want to do things with in your workplace, start a green group maybe, and just start somewhere. It doesn't matter where and which element of your life or work it is, but start somewhere and it will lead to more and more things coming up. So yeah, that's it from me. Do I need to stop
Veena,
sharing?
thank you very much. That was a really powerful reminder of why this is so important, and a really passionate plea for action. And I think particularly that the video has sort of pushed me to be perhaps slightly more hardline than I otherwise would. Can I suggest to people, if they would like to put any questions that they have in the question box, they're starting to come through. So Veena, a few questions for you if you've got time, if that's okay. So the first question is, what do you say to those who disagree with your fundamental remarks?
Disagree with which bits?
Well, it's difficult to have sort of back and forth on the questions, but that question appeared quite early on in your talk when you were talking about how climate change is the biggest threat to human health, and how the fossil fuel industry is waging an information war to try and maintain their profit margins.
I mean, that's not my opinion, so there's no point arguing with me about it. It's all pretty set in stone. I mean, if you want to disagree that the climate crisis is the biggest health threat to humanity, you can take that up with the WHO, I would say, because that's their quote, not mine. So it's not just my view. There are some people who might say that, and I say to them, well, there are people who don't believe in COVID. It doesn't mean there's no evidence for it. Like, this is very evidence-based, so there's not really much of an argument to be had, really, I guess. So yeah, and to those who would say that the fossil fuel industry isn't waging a PR war, but again, that is very well documented. There's evidence for that. You can just have a quick Google. All of these articles will come up. There are leaked documents. You know, there's plenty of actual evidence of their PR campaigns out there. So yeah, it's all out there. Some people.
Okay.
Yeah, it's a fact, really.
Okay, thank you. So there's another question here which I'm going to summarise, and the question is: besides reducing wastage, what are the other key arguments for how it benefits the economy? How climate change action benefits the economy?
Yeah, it benefits the economy in a lot of ways. I mean, a lot of jobs are created with green energy. Also, if you look at the economic impacts of climate issues, they are massive. Just the health impacts of air pollution alone cost billions of pounds to the economy, in terms of, you know, people who are too sick to work, in terms of hospital admissions. And then you've got the impacts of, for example, a flood or a heat wave when infrastructure breaks down, or when houses or towns are flooded, and then you have to repair all of that. So there are absolutely enormous economic challenges with the increase in climate emergency. So in terms of the health and the general societal impacts of it, there's positives to be gained from the green growth, but also, yeah, negative economic impacts from everything else. So yeah,
Brilliant.
those are.
Thank you. There's another question here. So I think it's amazing that you've had such exposure to the national team, and I'm keen to sort of extract all the wisdom I can from you. I'm sure while you were there were lots of sort of frustrations and barriers amongst the team, lots of enthusiasm, but still slow progress. Is there any one particular thing that clinicians can do to help effect the change? You know, was there any chat in the national team around, if only the clinicians would do X, then, you know, we might be able to turn the wheels a bit faster?
Yeah, it's a really good question. There's so much clinicians can do, and it's hard to say one particular thing, but I would say look at your own setting and what makes you unique. So you're an anaesthetist, you work in a specific hospital. Find out what's going on in your workplace. So I got back from my fellowship and I emailed the CEO and said, can we talk about climate? He said, yeah, okay. So talk to people in your hospital. They will talk to you. Don't be afraid of them. Doesn't matter what position you were. I was a GP ST2 at the time, you know, quite junior really. But it doesn't matter. Find who the sustainability board lead is at your hospital and find out what's going on. So they are hugely variable in terms of how much is happening, and you'd be surprised that, you know, some might be really far forward and some might actually not be doing an awful lot. So find out what is happening and try and hold them to account a little bit, but also see what you can do to help. So look at the nitrous toolkit, which I'm sure the others will talk about, because there's a lot of nitrous wastage that goes on. Look at your desflurane thing. You know, you can work with surgeons for green surgery. And then just find out what the board are doing, because they should be looking at things with a sustainable lens. So you might offer them to undertake board level carbon literacy training, and the Centre for Sustainable Healthcare can do that. And that can help them to think about the way they organise their hospital with a sustainability lens. So really it's about trying to get into the those in charge and just get it up their radar a bit, really.
Okay, thank you very much. So there's lots of questions coming through. I don't think we're going to have time to get to them all, but I've got one for you and then one that I'm going to answer, if that's okay. So the question for you is, how about medical education? How is climate change and sustainable healthcare tackled in medical education programs, UG, which I assume is undergraduate and during specialty training?
Yeah, it's a really good question. I think there's a lot going on. There's a lot of really amazing medical educators out there. And I know that there's a network who are now doing undergraduate education, who are trying to embed this as much as they can in the curriculum. And there's a thing called the Planetary Health Report Card, where they score the medical schools on, amongst other things, the quality of the sustainability in their education. So that's happening in the undergraduate courses. Postgrad, yeah, it's very variable. I don't know about all specialties and what all of them are doing, but I know that in the RCGP there's it's been put into the curriculum now. But whether training programs have it on their sort of list of topics for the term is up to them. Me and some colleagues are trying to get around as many as we can to teach, but there's 110 programs in England, so you know, we can't get around them all. And then yeah, I think it does vary a lot, but there are a lot of really passionate people. But yeah, if you're interested, then definitely worth trying to teach in your local area.
Okay, thank you. So the other question is that for the avoidance of doubt, does the AAGBI endorse membership of Extinction Rebellion? And I'm going to answer that. I don't think it's for the association to endorse membership of Extinction Rebellion. I think that's a personal decision that each and every one of us needs to make with our own conscience. What I do know is that, and Vina, you might be more up to date than me on this, but the last I heard, every doctor that has been arrested for taking non-violent protest action on climate change has reported themselves to the GMC, as we have an obligation to do if we're arrested, and the GMC has declined to take further action towards those doctors. So de facto, the GMC is permissive of registered doctors taking non-violent action on climate change. Is that your understanding as well, Vina?
Yeah, I agree.
Yeah, okay, super. Vina, thank you very, very much for your time. We're really grateful. I hope you have a great evening going on to whatever it is that you're going to do, but you're now excused. And thank you very much. We are going to move on.
Thanks for having me.
To hear from Lucy Brooks, who's going to talk on sustainable anaesthesia trainees perspective. Lucy's an anaesthetic ST4 working in West Yorkshire and is also one of the environmental advisors to the Royal College of Anaesthetists. She recently spent time out of programme as a leadership fellow in climate change and anaesthesia. And Lucy is passionate about educating healthcare professionals about environmental sustainability and the links between health and climate and ecological crises. She has participated in panels on the subject of sustainable healthcare, including for the National Health Executive and the King's Fund, and has published opinion pieces on the subject in the BMJ and in Anaesthesia News. So, Lucy, thank you for coming this evening. Over to you.
Thanks so much, Frank. And can you see my slides? Because I suddenly can't see my slides.
Yes, we can.
Right, how am I going to scroll through them? Hang on. Sorry, everybody. Apologies, this didn't happen in my trial run. There we go. Okay, I can see my slides cracking. So thank you very much for having me. As Frank said, I'm an anaesthetic ST4 in West Yorkshire, and I'm currently one of the environmental advisors to the Royal College of Anaesthetists. Although what I'm going to say today isn't particularly pertaining to that role, I do think it's relevant as a declaration of interest. So I've been asked here today to provide my perspective as a trainee, and I suspect that I'm preaching to the converted. Vina's already covered why this is the case, but I really wanted to reiterate that the climate emergency is a health emergency. Climate change is the biggest health threat facing humanity, and as doctors or healthcare workers, we have a responsibility to do whatever we can to safeguard the health of all people. And this by necessity means that we have to safeguard the health of our planet. Our day-to-day choices, both at home and at work, can have a huge environmental impact, and we should all be striving to reduce the harm that we cause. So that's my perspective, underlined here in red. And whilst I think that's very interesting, I thought it might be useful to think a little bit more broadly about training and education. So I'm going to do that, and then I'm going to focus a little bit on methodology for how we can practically make sustainable changes to practice through quality improvement and how that's relevant to all of us and particularly to trainees. So, on to trainees. Vina's already mentioned the legal obligations of the healthcare service as a whole, but more specifically, even if sustainable practice isn't top of an anaesthetic trainee's agenda, they do have skin in the game because sustainability is now on the training curriculum. And this matters to consultants and other non-training grade anaesthetists too, as they're expected to teach trainees and to help them achieve these competencies. And this might mean that they also need to upskill in this area. So when planning sustainability education, trainers need to be cautious to not forget all of the sustainability challenges in anaesthesia. I know we're talking about climate change, and Veena mentioned about some of the net zero emissions targets, but we must include other environmental harms such as air quality, pollution, biodiversity and climate justice. Carbon equivalent emission reductions are very likely to be prioritised, as they currently are, as the 2040 net zero target deadline approaches. So I'm concerned that all focus might be shifted to this and we might miss our opportunity to make positive changes in other areas. So this is really just a shout out to say, don't forget about the rest if you're going to be teaching about sustainability. I also think that how we deliver sustainability education is important. Teaching principles of sustainable practice from the beginning of training is key to embedding it into our future practice. But senior colleagues must also be educated to prevent these principles being undermined by the hidden curriculum. And by that I mean a contradictory culture, the implicit social norms and the traditional practices in an organisation. So for example, the opening of equipment and drugs routinely that are often discarded without being used, or putting domestic waste in a clinical waste bin because alternatives are unavailable. So we should be striving to create a culture in departments where sustainability really matters. The college has created online resources to support anaesthetists wanting to learn more about sustainable practice, and departments should encourage all staff to engage in the learning. However, the departments also need to provide time for people to do this, both trainees and trainers. They must ensure that there's infrastructure in place for anaesthetists to put their learning into practice, and that might look like ensuring provision of training and equipment for TIVA, or ensuring the availability of alternatives to desflurane, and including the principles of sustainability in the writing and review process of their departmental policies and care pathways. I think we should also be mindful of how we host educational events like this one and host our training days. So for example, thinking about the environmental costs of travel to events, printing paper resources and the food and things that are provided. So there's lots to do with sustainable education, and it's not an easy thing to tackle. I think when it comes to making sustainable changes in practice, even the most enthusiastic trainees can still run into some challenges. So what are the challenges of being a trainee trying to make sustainable changes and practice sustainably? Well, you have very little choice about where you go, often as a trainee, and you may be sent to a department that doesn't prioritise sustainability and doesn't have the culture there to make sustainable changes happen in practice. You also might just be finding your feet when suddenly you're whisked away to another location. That might be at 12 months, but it could be at 6 months, or it could be at 3 months. And that frequent rotation, not only is it very unsettling, but it makes it extremely difficult to embed any change in a department if you notice something that you think could benefit from some quality improvement. It's also difficult if you don't know the right people. You know, who are the right people in this space? Is there a sustainability lead in your anaesthetic department? Is there a sustainability lead for the trust? Is that the same person as the waste manager, or is that someone different? Is there a medical gas committee? Well, there should be legally, but who's in it and how do you get involved? So I think that's a challenge, and having that information available to trainees when they start can be really helpful if you want to embed them in this sort of work. And if you yourself are the right people, you know, if you are the sustainability lead for anaesthesia, then make yourself known to trainees, for example, showing up at induction and introducing yourself, because I think that makes a really big difference to people feeling like they want to get involved. I think there's a challenge with not knowing the local systems, not knowing how things work in the hospital where you are at that time, particularly on a short rotation. And a perceived lack of power, you know, being just a trainee. And the title of this webinar today is I'm just an anaesthetist. Well, if you're just a trainee, how do you have the power to influence change? And I would say that you'll see from the speakers on this panel today, trainees can have a huge impact and influence a lot of change. So if you see that sort of attitude, I implore you to nip it in the bud. I also think there's a huge amount of competing priorities. You know, we have a long e-portfolio, exams to take, there's a huge number of requirements for progression. And I think that those can sometimes get in the way of the other things in life that aren't just showing up for work, doing some anaesthesia and going home again. I think people sometimes come across a this is the way we do things here culture, and that's why I talked about the hidden curriculum. And there are lots of ways that we can all tackle this. I've recently rotated trust at the beginning of August and had a fantastic induction, and it's rare that I would say such a thing, but I have to say my college tutor gave us the intro to the department, and in that they included a slide talking about sustainability, environmental sustainability, and the things that we do at this trust that make us all of our practice more sustainable. And I felt that that really gave me permission to talk about sustainability within the department. So if you're interested in this and you work with trainees, speak up and tell them that they can too. I think, again, I've mentioned about trainer knowledge and experience. I did some work locally in West Yorkshire, a survey that found that 25% of consultant anaesthetists didn't feel comfortable providing TIVA. And I think that's something that goes hand in hand with the challenges of teaching something when you don't feel confident about it yourself. And I think lastly, the thing that's the real challenge is the knock-on effects on your career progression. But what if I rock the boat? I'd really like to get a job here, particularly as you become a more senior trainee and you've finished your exams, all your e-portfolio is looking done and you're thinking, right, I want a job now. And you really don't want to rock the boat somewhere where you'd like to work. And that can stand in the way of making waves and trying to make change happen. But it isn't all doom and gloom. In fact, I would say that trainees can be an asset to a department trying to make sustainable change happen. Some of these issues are about perspective. So, for example, frequent rotations, whilst I do think that 3 months is too frequent, but frequent rotations can enable sharing of good practice across the region. Oh, I saw the way they did this here, and I'd really like to bring it, there, and I'd really like to bring it to here. It's also an opportunity for fresh eyes, people who come in and notice opportunities to change things for the better, where they've been missed by other people because that's just the way they've always been done. And a good example of that I've come across recently is walking in and finding clinical waste bins under hand washing sinks, where they could easily have had domestic waste bins, for example. And that's just the way it's always been there, so that's the way it's done. But there's an opportunity to change there. Frank mentioned about how all three of us this evening have taken time out of training to do, to explore sustainability. There's lots of opportunities as a trainee to gain more knowledge and in-depth knowledge of things that you're interested in. And I can say that my fellowship was truly life-changing for me in terms of the opportunities it's brought me and what I've been able to learn. I also think that whilst I mentioned competing priorities, e-portfolio and our requirements for progression includes quality improvement. Now, quality improvement being included in this means that we should be entitled to educational development time to do so. And I'd really encourage you to encourage trainees to take their allocated educational development time to do something and do something meaningful, not just another hand washing audit. So what could be meaningful? Well, we all have to engage in QI projects, and what could it be like if sustainability became part of that? Well, I'm actually not the first person to ask that question. The Centre for Sustainable Healthcare has developed a programme called SUSQI, Sustainable Quality Improvement. I was fortunate to attend one of their courses on teaching SUSQI during my fellowship, and they provided a range of resources on undertaking sustainable quality improvement, including a slide deck for educators, and some of these I'm going to present to you now. Where I've used or adapted their slides, you'll see their logo in the corner. So why should we focus on quality improvement and sustainability in quality improvement? Well, the Royal College of Physicians has identified sustainability as a domain of quality which must run through and moderate other domains. So that means that this is a really legitimate thing to be focusing on in terms of quality improvement if you're taking it to your QI department to say, look, this is important, this is a domain of quality, not only part of the sustainability agenda. And building on what Veena has said, a service might be of high quality, but of low value if the resources that were used could have provided a greater benefit had they been used differently. So sustainable value explicitly considers the environmental, social and financial impacts in relation to health outcomes for patients and populations. It maximises outcomes for patients and populations, minimising environmental impacts, adding social value at every opportunity, and keeping finances and cost neutral or reducing them. So if you're a college tutor or an educational supervisor and a trainee says, I need a quality improvement project, you can help them find a suitable project by setting them the challenge to find the best way to add sustainable value to their service. The SUSQI framework provides an approach to integrating sustainability into mainstream quality improvement methodologies. I'm conscious of time because someone just dropped me a message and let me know how long I've got left, please. When it comes to their four methods as seen in this slide here, the first one is setting goals. Within this, the narrower goal we defined for a specific QI project beyond just maximising sustainable value. And you can look at your service and see where you think your hotspots would be, things that you could tackle. When studying the system, you can look at how to solve problems. And the QI approach encourages us to really find out about how the system works currently. So who's involved? What are the steps in the process? In SUS-QI, this also includes understanding how and where environmental, social and financial resources are being used, highlighting problems and opportunities for improvement. Process mapping is used to develop a map or a flow chart. It maps out the process, how it operates in practice, and really in reality, rather than how it might ideally work. It can be used to help a team understand where the problems are and identify areas for improvement. Process mapping can provide an ideal chance to consider the environmental, social and financial resource use within the current system. So this is an example from the Centre for Sustainable Healthcare, from a process map of studying the system in A&E. And whilst it's examples from A&E, I can imagine similar maps mapping the pathways that are involved in the perioperative patient pathway. And this is quite a complex slide, but you can see what they're saying is some patients have unnecessary cannulation, and therefore you could target that as a way of reducing harm to patients and of reducing resource use. So I think that there is, this is a nice straightforward example. Thinking about a more complex example, this is a process map that I made of a potential patient pre-op journey. And I would say that this probably doesn't go into enough depth. You might choose to focus on just one aspect of this and process map each stage in more detail. But what it does show is how repetition of use of resources could potentially help make the case for a single one-stop clinic for pre-op assessment, which would be attended immediately after having seen the surgeon in the surgical clinic. And I know that some hospitals are already doing this, but what this would do would reduce the need for patient travel and patient time. And there are significant harms associated with patient travel and patient time. For example, taking more time off work, for example, paying more for transport to the hospital or parking at the hospital. And we could reduce that a lot. The other thing is questioning whether or not we might be able to reduce some of the other things like energy use and water use through trying to combine as many things together as possible. And I think that would be slightly harder to navigate here, but because you'd still need different spaces to run these different aspects of the clinic. But certainly from a social resource perspective, I think patients would really benefit from this. And so, this is just an example, but you could take just one of these steps, like the requiring anaesthetic review step, and process exactly what happens. For example, nurse brings notes or sends email to anaesthetist, anaesthetist answers email, anaesthetist reviews notes, anaesthetist decides if patient needs to come into hospital or not come into hospital or requires further testing. And you can see where in the steps you could create leaner pathways, which was something that Veena spoke about earlier. So what are the next stage? Well, the next stage, or what is the next stage, is designing an improvement. So you've had a look at your goals, you've looked at the system and seen where changes could happen. And the next step is to come up with and test change ideas. So this needs to be a combination of changes trialed, and that's sometimes called the improvement effort if you're into QI methodology. So the Centre for Sustainable Healthcare defined 4 principles of sustainable clinical practice, and Veena mentioned these earlier. The aim of this is to first minimise the need for healthcare activity and then to reduce the environmental impact of the activity that is still retained and requires to be provided, whilst maintaining or improving health outcomes. So the principles are numbered in descending order of importance. The first, as I mentioned, being prevention and not needing healthcare. And for anaesthetists, that might look like us getting involved in high-risk surgical clinics and helping patients to make patient-centered decisions about whether they want to proceed with surgery. It might look like the second point being patient empowerment and self-care. The third being lean systems and pathways, and that may be combining a pre-op assessment clinic, as I've mentioned. And the last one is preferential use of technologies and interventions with lower environmental impact. So you can see some of those different ideas here, and whilst the ones that are listed here are not specific to anaesthesia, you can think about how that might apply to our specialty, and how we could, I think, particularly lean pathways in the perioperative care pathway, and low carbon alternatives in the treatments that we provide both in anaesthesia and in intensive care are really relevant here. So applying these principles to the problem you're tackling that you've identified through your process mapping can help you to generate change ideas to help improve sustainable value. So this here was an example of potential improvement in a scenario of an elderly patient with a high rate of readmission for mild exacerbation of their COPD. And actually, I do think there's a role for anaesthetists to play in preventative healthcare, for example, things like routine offering of smoking cessation help. I'm not saying we have to provide it, but we should be able to refer patients to it whilst they're an inpatient perioperatively. So then what? Well, the next thing is to measure impact. Now, once the change idea has been tested and anything that's proved useful has been implemented, we need to measure the overall impact of the work and to work out whether or not you've actually achieved the goal of improving sustainable value. And what you need to do if you're looking through the SUS-QI lens is to consider each of the 5 variables in the sustainable value equation. So that is patient health outcomes, population health outcomes, environmental impacts, social impacts, and financial impacts. Measuring each of these can be easier said than done, but it is important to have a go and at least discuss them. Particularly measuring things like social impacts can be quite challenging. But as I said, with the pre-op care pathway, you can see that the impact on patients of not having to come to hospital as many times would be beneficial for many. A quick and simple way of measuring environmental impacts without doing a carbon footprint is to make a list of all of the healthcare activities that they're involved with. Oh, sorry. That are involved in that patient interaction. So you would make a list of all the resources currently used, and then you would measure and record the amount used before and after the intervention. And then you can list and measure them, and you can see if the resource use has increased or decreased. And if it has decreased, then you can be happy that the negative impacts have reduced in terms of cost and environmental impact. Or you can measure specific environmental costs by units of healthcare activity. And that's what's shown here in this example. So this would mean that you would look at each of these individual things, find out what the carbon footprint is, for example, of a visit to the emergency department, and the Sustainable Quality Improvement website provides quite a lot of details giving carbon footprinting in units of healthcare activity, which is really very, very helpful if you're looking to do this kind of work. And one of my favourite things about using this methodology is that by measuring sustainable value, you often find that the environmentally sustainable care is also better for patients and staff from a social value perspective, but also it's often more economically valuable as well. And Vina touched a little bit on that, certainly with her response to some of those questions. So I think that even where there's not a particularly sustainability aware culture, using the SUS-QI framework in quality improvement means that we can include sustainability in an entirely legitimate way. So you can find a whole bunch of real case studies for SUS-QI in action on the NHS on the SUS-QI website, which is susqi.org. And there's an example here from Devon. This is a little bit out of date now because it was about 5 years ago. I think we're all much more aware of the harms of nitrous oxide as a greenhouse gas with potential to cause both global warming and deplete ozone. But just to give an example of how this relates to us as anaesthetists, this was what they identified as a problem through their process mapping. They studied the system here and found nitrous oxide use to be particularly relevant from an environmental perspective. So that with the help of the sustainability officer, the team undertook a scanning for resources exercise, which is how they came up with this process map. And then they detailed out the environmental, economic and clinical impacts as I've described. So the next thing was to design the improvement. And this team looked at low carbon alternatives, particularly thinking about reducing the use of low carbon alternatives to treatments and reducing the use of nitrous oxide, for example, replacing with air as a carrier gas. And so what did they actually do? Well, they identified this problem, they had conversations with people, they engaged an education programme for the staff locally, and they created reminder stickers to encourage people to reduce their nitrous oxide use, which could then be found in theatres. And then they went on to measure the impact, as we've said, and they've had quite a good output insofar as they reduced nitrous oxide use by 25%. And that's sort of clinically reported usage rather than, we're not talking about nitrous wastage and leakage, which is covered in more detail by the Nitrous Oxide Project. But they also found that it had a reduced risk of miscarriage for staff. There was a huge reduction in nitrous oxide use, over 70,000 litres. They've saved some money, and they also were able to increase TIVA training for all of the staff in the department. So, this is, as I say, one of the great things about looking at quality improvement, which is mandatory for all of us, particularly as a trainee for progression, and how we can embed sustainability in the way we do things rather than simply trying to shoehorn it in. So I've mentioned this website, susqi.org. It's absolutely brilliant. The Centre for Sustainable Healthcare have really fantastic courses. If you've not been on any of them, I really thoroughly recommend them. But they also have a huge amount of stuff that gives you a lot more detail about this sort of very whistle-stop tour of the methodology. But I thought it was important to actually leave you with something you could take away and implement when you go to work, tomorrow or the day after or next week. So that's all I'm going to say. I do think it's really important to acknowledge that the climate emergency is our problem. We are part of the solution, and that making changes is hard, particularly as a trainee. I think that when we're teaching anaesthetists of tomorrow about sustainable practice, it's important that we recognise that we're part of this solution. But it's not enough in isolation to just teach trainees. The changes to the curriculum are going to take quite a long time to embed into practice. But the climate emergency is a health emergency. An emergency means we need to take action now. And as doctors, we're promising to first do no harm. We must adapt our practice urgently, and recognising that that's what is bad for the planet is also bad for our patients. And whilst making change as a trainee is challenging, non-training staff have a really important role to play in tackling these challenges. Opportunities do exist for trainees to be agents of change, and the SUSQI methodology provides a framework to embed this into our mandatory quality improvement work. We need to focus on embedding sustainable value at every opportunity. Thank you very much.
Wow, Lucy, thank you very much. Not only trainees' perspective, but also a crash course in what trainees can do to really impact the system. Thank you very much. You're off the hook for a short while. We're going to come back to questions at the end with you, if that's okay. But if people do have questions, and there are questions coming in, but please do continue to put them into the question box on your on the right-hand side of your screen there. As I said, I'm really keen that attendees get as much value as possible out of this session. So without further ado, I'm going to move on to our third amazing inspirational speaker for this evening. And that's Dr. Esme Ward, who's going to talk to us about, after desflurane, what's next for anaesthetist. So Esme is an anaesthetic ST4 trainee in Yorkshire. She's recently returned to clinical practice from a year-out programme as a leadership fellow in sustainable anaesthesia with the Future Leaders programme in Yorkshire. So Esme, over to you.
Thank you, Frank. And again, I'm having the same problem as Lucy, so just give me a second. Can you see my screen okay?
Yes, we can.
Grand. Okay, so thanks for the intro there. And thanks to Vina and Lucy for that kind of introduction into this part of the talk. So really what I want to do here is talk a little bit about where we are now, talk about what we can learn from what we've done, particularly with desflurane, and then to give some examples or some ideas of what could be next for you in your setting, in your hospital. This isn't meant to be a kind of list of projects to do, but it is meant to kind of inspire people to go, oh, that could work in my place, that could really apply to this, and hopefully we can all take away some ideas and take some action on from now. So we've been through this, but I think it's really important to just keep reminding ourselves that looking after patients means looking after the planet. So it's something we need to think about with everything that we're doing in healthcare. So I'm going to start a little bit with some of my experiences, and this is my personal reflections on what I learned from the journey of getting rid of desflurane. And I know it's kind of back in our consciousness at the moment. I'm not going to dwell on that. I'm just going to talk about my experiences so far. So when I was a CT1 anaesthetist in 2018, I started working with Frank, looking at reducing desflurane in our small district hospital in Yorkshire. And at the time, I thought, this is easy. We've got something that's worse. We've got something that's better. We'll just tell people, and that will be it. That's not what happened. So my experience from that perspective was that it was quite hard. It was quite isolating to go into that setting as a really junior trainee and try and change something. And what I realized was that it wasn't just changing a practice or a rule, it was changing people's behaviors, and that can be really hard. And to do that, you really need to find what makes them tick. So that's something that I've taken on with me in my future projects. And it takes time. It takes little bits of work that all add up to make this big change. And at the time, it can feel really really slow and really disheartening. And that's why it's really important to work with others, so that even if whatever you're working on specifically isn't going that well at the moment, you can share from other people, you can share with their successes, and you can learn from each other's failures. And I think what we actually learn is that we can make system change, we can make decisions based on environmental issues and make them into something that we share across the nation. So the rest of what I'm going to talk about is mostly from these two articles in the Anaesthesia and the BJA, and it's basically just an outline of areas that we know are an issue and that we can kind of tap into to try and make our practice more sustainable. And again, throughout this, I'm going to be using these principles of sustainable healthcare, which we talked about already, but I can't stress enough that the number one is the most important. So if we can prevent things, if we can do less, if we can make things more streamlined, that is all better than doing the same thing just in a better way. So that's what I'm going to try and emphasize during all of these points. So why are we having this chat? So we've seen this picture already, but what I want to point out here is in the green scope 1 emissions, anaesthetics is highlighted, and that's why really us as a specialty started moving forward and really starting to be leaders in this sustainable anaesthesia movement and the wider sustainable healthcare movement. And I think that we can really be proud of that, and we can carry that forward. And all of these other things on the diagram there might not seem like they're within our influence, but actually we have a big influence across the whole hospital and across the wider system as a whole. So actually, I think we have quite a lot of power, and we should be use our successes to be motivated to change things. So I'm going to run through the principles outlined in those articles there, and the first one is the easiest one to talk about. So it's the things that we do day to day, the things that are in our direct control, and the things that we do within our anaesthetic practice. So we can choose to do things in a way that is environmentally preferable, and that can include reducing our inhalational anaesthetic use, perhaps to look at some innovation, and then to move on to these other low carbon techniques. So I'm going to talk about each one of these just very quickly. So these are the actions outlined by the Anaesthetists Association of Anaesthetists in their Green Guide on how we can reduce our anaesthetic gas use. So avoid desflurane and nitrous oxide. Lucy talked a bit about the nitrous oxide project. Have a look what's going on in your hospital. Every place is in very different stages with this, and actually coordinating with different hospitals, coordinating with your medical gas committee might be a good kind of starting point to take on a project that's actually quite well defined already, but can make a very big difference. Other simple things like using low flow anaesthesia, or making sure you're not filling up circuits unnecessarily by disconnecting and reconnecting them without turning off your flows. Some of the newer machines will help you with that and make it quite easy with the end tidal anaesthetic control. And we can also think about what else we're doing within our complete anaesthetic technique. So can we use things to reduce our gas requirements? So things like using opiates or ketamine or other things, which I'll talk about in a minute. So innovation, I'm not going to dwell on this. This is a whole talk on its own, but there's a lot of talk at the moment about these two things. So anaesthetic gas capture and nitrous oxide cracking. They, like many of our kind of green solutions, are not the answer to everything, but they might have roles in specific circumstances. So very briefly, the anaesthetic gas capture just connects onto the gas scavenging system and takes out the inhaled anaesthetic and stores it in a canister. The problem is what happens with that canister next, and that's not something I'm going to go into here, but it's a nice idea, and if we can sort that out, or if we can repurpose that paper and get it licensed for human use, that could be quite exciting. The nitrous oxide cracking, again, has certainly a place in places like maternity, where nitrous oxide probably isn't going to go away. But both of these things are very expensive, and I think require a lot of discussion amongst your departments about whether it's going to be the best way to spend your time and energy. So these things are things we can do. So use lower carbon alternatives. So that's compared with your gases. So using TIVA, again, along with a lot of these environmental arguments, there's a lot of nuance and there's a lot of things we don't know, but we do have a big life cycle analysis from over 10 years ago now that says that in most cases, TIVA is environmentally preferable. Also using regional techniques, we know that's a really nice example of the triple bottom line. So we know that it's better for the environment, it's often better for patients, and you're using less equipment, and it can often cost less as well. And using alternatives to Enclinox. So in your labouring, women can use an epidural, can use a remifentanil or PCA. In your emergency department, can you be thinking about Penthrox? So they all seem very relevant to our daily practice. The things I'm going to talk about from now on might not seem like you have so much control over, but actually I hope to highlight that in a lot of these places you do. So taking that first principle of sustainable healthcare, we want to be doing less. So we know that operating suites produce around 1/4 of all hospital waste, and 1/4 of that comes from us as anaesthetists. So we just need to be using less. Some examples of this are, so in our region, we've run a project looking at equipment packs. These are pre-made packs for things like your central lines or your arterial lines or your regional anaesthesia. And we saw that across Yorkshire, on average, 3 items are getting thrown away from every pack. This is stuff that's not even single use, it's 0 use. It's getting made, a lot of it's plastic, which we know comes from fossil fuels, a lot of it's metal that has to get mined, that is then getting shipped manufactured, shipped across the world for us to just throw away, and that's really not good enough. So what we can do with that information is speak to our procurement teams, speak to the manufacturers, and try and get that changed in a way that's also in line with that triple bottom line, in a way that's acceptable to the people that are using those packs and is not financially detrimental. Another example of using less is the Gloves Off campaign, which looks at using an educational campaign to look at when it is appropriate to wear gloves in clinical practice. And actually, the centres that have run this have seen huge reductions in, obviously, PPE use and also cost savings just from this simple educational intervention. And doing less can extend to other things. So think about your ICU patients. Do they need bloods every day? Do we need to do all the investigations for our pre-op patients? Just being really mindful about how we use stuff is really important. So when we have reused stuff, it has to go somewhere. So this is the waste hierarchy. It's kind of like the reduce, reuse, recycle in a bit more depth. So when we're looking at, we've looked at prevention, so let's think about how we can reuse things. Again, this is tricky. We need life cycle analyses to know whether actually a single-use item is worse than a reusable, sterilizable item, which requires a lot of energy and heat to reprocess. But these are things we need to be looking at. They're things that we need to be considering rather than just saying single use is best all the time. Or is there somewhere in the middle? Can we speak to manufacturers and use a kind of hybrid item where only part of it is thrown away? Without us suggesting these innovations, they're not going to happen. And then we're moving on to what happens when we get rid of our waste. And we have to remember that there's no way. Everything we use has to go somewhere. So we need to make sure it's going to the right place. So another really simple intervention is to just think about where your waste goes. So make sure you're putting it in the right place. Make sure your colleagues are putting it in the right place. If you don't have the right bin somewhere, speak to your waste management team. Every one of these waste streams is disposed of in a different way. Often it's for the highly dangerous, harmful items. It's high temperature incineration. This uses a whole bunch of energy. So anything that we don't have to put in that waste stream will be costing us money and be environmentally detrimental if we're putting it in the wrong place. And another thing to think about is our drugs. So again, we want to not be wasting our drugs. Looking at propofol in particular, there's a survey that says around half of all propofol in theatre gets wasted. And then where does it go? We need to make sure we're getting rid of our drugs in the right place. So often drugs can get into the water systems, and we only measure about 9 or 10 of these as a standard, but we know that all of these drugs can be present. Propofol, for example, is not biodegradable, so it persists in our water streams, and it's really toxic to the organisms that live in them. A lot of this doesn't come from us, it comes from patients excreting these drugs, but actually we've all seen someone squirt a syringe down a sink. That goes somewhere. We need to think about where we're putting it. And if you look at some of these other ones, so we can see that antibiotics on there, that's going to cause antibiotic resistance, and we're seeing some major problems with that just by this disposal into our water systems. And another area where we can reduce waste is energy energy use. So we know that theatres and ICU are high areas of energy use in the hospital, especially thinking of our ventilation systems and our gas scavenging systems. In particular, many of these are left on for 24 hours, even when the theatres are not in use. And the same for other pieces of equipment. So, for example, a computer will use 2/3 of the energy when on standby as it does when in full use. So things like simple changes, speaking with your theatre team to modify the theatre shutdown checklist, or speaking with your estates team to see if there's any setback protocols that can be put in place, can really make a big difference to this energy wastage. And where our energy comes from is important as well. So we know that we use a lot of energy for reprocessing and sterilisation of equipment. So it's really important that that energy comes from somewhere, from a renewable source. So this graph is from the IPCC report, and it shows the carbon intensity of different electricity generation. And the reason I put it here is we all know that gas and oil are bad and coal is bad, but actually how much worse are they in terms of their carbon intensity? And while you may not feel you have much of an impact on this in your hospital, there are ways that you can influence change, such as discussions with your estates department about where their energy comes from, or in your own life, so thinking about your home energy supplier, or thinking about where your money goes, so banking with a bank that doesn't use your money to fuel fossil fuel companies. Travel is important because we know that around 5% of traffic on the roads is on NHS and social care business. So we need to reduce that, and you can think of that from every level, from your own travel to work, to reducing patient travel, as Lucy was talking about, in the lean patient pathways, and on a wider scale, how can we influence change to make our infrastructure better and more accessible for everyone? And this is simple. I'm not gonna talk about it too much, but if we can't travel, that's better. If we can active travel, that's better. And that's better not only for the environment, that's better for your patients. They're getting outside, they're getting some exercise, they're getting the cardiovascular benefits of that, they're getting the mental health benefits of being outside. And we're reducing air pollution, as Vina was talking about earlier. As we move down this, if you can't avoid using a vehicle to travel, think about whether you can share. Think about what your vehicle is, and the estates departments and the fleet can think about what their vehicles are. So can they be electric vehicles? And Lucy's spoken about sustainable quality improvement, so I'm not going to go through this, but I just want to emphasize that every project that you do needs to have a consideration of environmental sustainability, and every project that you do is a sustainability project. We need to normalize talking about the environmental impact of what we do, not just the financial impact or the saving in bed stays. Once we normalize that, it will keep going and spreading, and that's what we need to see. And again, Lucy's talked about education, but so it's not just the formal educational opportunities, it's our everyday practice that we need to share this knowledge with each other. And if you don't know something, ask somebody, go and read about it, go and find out about it so you can share. As Vina talked about earlier, we need to advocate. We need to make better choices and advocate for better choices for our patients and for the environment. Vina talks about the issue of inequality. We know that the people that are most affected by climate change are not the people that are causing it. And they're often the people that don't have a voice. We have a voice, so we need to use it. And this is where leadership comes in, and it's not just from above. We can all be leaders in this. We have the power to influence a large amount of what happens in a hospital. As I said before, we work in theatres, we work in ICU, we work in the emergency department, we work in outpatients. Taking on these kind of leadership opportunities to really influence sustainable activities in this area is crucial to take this forward. And we've already learned so much, and we've learned that we can make change. So we really need to keep that momentum going. And this is my final point, but I really can't emphasize more the importance of collaboration. It's really inspiring to me that there are 300 people here tonight that have given up their time to consider how they can make a positive impact. And I really want you to harness that and share that and go back to work tomorrow and talk about it, and not just to your anaesthetic colleagues. Go and speak to your surgeons, go and speak to your theatre teams, go and speak to your pre-assessment teams, your estates managers, your sustainability management, your procurement teams. They're all keen to do something as well, and we can really thrive off each other's energy. And especially people like the sustainability managers, they're getting paid to do these things. They want to make sure that the things that they are doing, the interventions that they are making, are important to us. So we need to tell them what we would like to see. And there are many kind of groups and networks that you can join to get information or to share ideas with. So I've just shared a few of them here. So the Future NHS has a forum. There's a lot of good activity on there, and the Centre for Sustainable Healthcare also have a forum. And there might be kind of region-wide networks. So in Yorkshire, we've got the Yorkshire Green Anaesthesia Society. So that was a whole bunch of things, but what I wanted to emphasize is that there are a lot of things to do, and it's picking that thing that can work in your area. It's really tailoring these things to make them sustainable in the sense that they have longevity, and sustainable in the sense that they really make an impact. And this isn't all the things, this is just bits to start with. So I really hope that there's something in there that has kind of triggered a thought that you can take forward with you. And I'd really ask you to take a moment to think about that and think about what change you're going to take forward. Thank you.
Esme, thank you very much. Well, we're going to move on to questions now, and I hope that you're all feeling very inspired and motivated and impressed by the expertise and enthusiasm shown by our speakers this evening. There are some questions coming through, but please do keep typing them in the question panel if you would like your questions answered. We've got lots of time for questions. So first up, and to both of you really, as a junior doctor, how do we motivate senior colleagues to start thinking about sustainability in everyday clinical practice?
I think we have to talk about it, but you know, I think that it's really interesting when you start talking to people about it. Everyone has an opinion, and so I think sometimes it just takes. Sometimes it's a question. You know, oh, I noticed you used nitrous there. Why? You know, feign a bit of ignorance to open a door if you need to. But I also think just being bold and saying, this is what I'm interested in, what do you think? Particularly, it's quite topical and current at the moment. I've had lots of people asking me about TIVA and about desflurane again recently, and I'm sure some of the people here today will want to talk about that too. So I think that just starting a conversation is really important. And I also think that what Veena said is right, not being afraid to go up the ladder and just send an email to somebody that you think that you're not powerful enough to talk to, because actually my experience is that senior staff often are very, very keen to get involved and very, very keen to hear from us, particularly if we can share practice from around a region as rotational trainees. So that would be my advice, is just start talking about it.
Yeah, I agree. Even the kind of negative replies that you get to things, or the slightly sarcastic replies, actually is a conversation, and that's helpful. And understanding where those comments come from and trying to work with that is going to be the thing that creates change, not ignoring it.
Thank you. Again, both of you, but perhaps specifically to Lucy, I'm going to address the elephant in the room. This is one of the questions that's come through, and I'm abridging it slightly, but there was a session at the annual Congress that asserted no climate impact of anaesthetic gases, calling for the reversal of the ban on desflurane. How do we continue to justify the removal of desflurane in light of this conflicting evidence?
Thank you for that question. I do think this is really important that we talk about this at the moment. I will specify that this is my personal opinion rather than a college endorsed opinion. Sort of behind the scenes at the college, we're still having discussions about, not about bringing desflurane back, but about if there are ever clinical exceptions when it could be used, and reviewing the evidence for that. And there is a review from NICE coming out that will give a lot more, sorry, from NHSE, that is going to give more information about their evidence review and where they come down on that. And that's all happening in progress at the moment. I think that it's really complicated. I think Esme highlighted really well a lot of the things that we learned from desflurane. And I think we were all acting in the best actions with the best knowledge we had at the time. You know, the NHS England and the Greener NHS team told us that as clinicians, that anaesthetic gases had a big impact on the environment, and we made changes based on that. As clinicians, we are not climate scientists. We are evidence-based, and I think we do have to be humble and admit that perhaps the evidence basis behind all the things that we thought we knew is not what we know, or it's different from what we thought we knew. But there are so much that we can learn about desflurane and the power of making a system-wide change based almost purely on environmental grounds is absolutely huge. So I really think it's important not to lose sight of that, because I think the impact of saying anything otherwise is very detrimental for morale and for getting people to do the work. When it comes to actually should we be bringing desflurane back, my personal opinion is no. I don't think the evidence supports any benefit to using desflurane over alternatives, and having reviewed the evidence myself under any clinical circumstances, it's all rather equivocal, certainly not beneficial of using desflurane, and the evidence that pharmaceutical companies use to sell you and tell you that it does is based on small statistically significant differences but not clinically significant differences in things like wake up times, for example. And I think that there's other things that other than just the gas that we're talking about. We're also talking about having a second set of vaporizers. We're also talking about having a second set of systems to maintain those vaporizers. So I don't think we should be bringing desflurane back. It's more expensive. We've talked a lot about the triple bottom line and how sustainable value isn't just about the environment, it's also about money. And we know that, give or take, every pound you spend on sevoflurane, you spend about £4.80, nearly £5 on desflurane for the same clinical effect. And that's without paying for the second vaporizer and maintenance program for that. So I do think that even without environmental grounds, there's reason not to be using it.
Thanks, Lucy. Thanks, Lucy. Esme, I'm going to turn to you with another question. How do you manage eco-anxiety? Can you give us any tips?
So I'd say my last point of talk to people. I think it's often can feel like a bit of a journey. It can feel very up and down. It can feel very hopeful one day, and it can feel completely not the next day. So sharing that is really important. So make sure you've got a good group of people around you that understand what you're feeling and what you're talking about. And for me, that group of people is here.
Thanks, Esme. I've got a couple of sort of more in the detail questions, practical questions now. Is there a flow rate at which inhalational anaesthesia is more carbon efficient than TIVA?
Perhaps that's a question for you, Frank.
Well, I was wondering if you would want me to have a go at that. My answer to that is that it's really difficult to answer, and partly for reasons that we've heard this evening, because it's very difficult to compare the global warming effect of our anaesthetic gases with the effect of propofol, for instance, on the aquatic environment, because that's a little bit like comparing apples with pears. And I think, therefore, the only answer is to take a sort of precautionary principle and use the best information that we have. So, for instance, if you want to give a vapor anaesthetic, use sevoflurane, don't use nitrous oxide, and keep your flow rates as low as possible. And if you're using a TEVA anaesthetic, try to maybe keep your propofol use low, and that might be by using more remifentanil, or there are several people, and I sometimes use a technique where I use a little bit of sevoflurane and a little bit of remifentanil, and that seems to work quite well as well. But I think it's very difficult to give a definitive answer to that question, because it's not quite as simple as that. So the next question is, single-use laryngoscope blades are made of an alloy called Zamac, which is zinc, aluminium, manganese, and copper. There is only one EU plant that can recycle Zamac. So is it time to rethink the use of reusable laryngoscope blades?
Yes. Definitely.
Well,
I think that, yeah, well, the evidence for switching away from reusable airway devices in general is not great. It doesn't, in terms of thinking about prion diseases and things in relation to anaesthesia specifically. And I think that Esme touched on the challenges of reusable versus single use from a carbon footprint perspective. The sterilisation is challenging from an energy perspective, but in items that are heavily used, so not only brought out by a surgeon once a year, almost always the environmental footprint, not just the carbon footprint, but the whole environmental footprint, including transport, water, air pollution, all that goes along with it, is better for reusable than for single use. So I think that we really need some decent evidence to convince me that single use is better in that specific situation.
And there's a lot of work out there looking at things like this. People do the hard work for us. So there are databases of life cycle analyses of things like laryngoscopes, where you can look at the data in an accessible form and make your mind up based on that.
Thanks, Esme. I think there's another dimension to this question as well, which is the introduction of single-use disposable video laryngoscope blades, which are definitely becoming more prevalent in my hospital. And I haven't seen any sustainability data, but it is my impression that there might be a possibility to use those single-use blades, because I think that the embedded carbon within those blades is likely to be much less than using the metal alloy blades as single-use disposable. And there's also, I would argue, a clinical and an educational benefit, because when you use a video laryngoscope, everybody in the room can see exactly the same as the operator. And certainly as a consultant supervising particularly very junior trainees at this time of year, that can be very good for reducing my heart rate and keeping my angina under control. So I can see a future in which perhaps we move away from fossil fuel plastics for creating those blades, and might use bioplastics that could be disposable or biodigestible. And I know there are a lot of problems around sterilizing those blades at present, but we're getting there. It's coming. We might even be able to 3D print those blades on site in the future, which would reduce our transport costs for those blades as well. Okay, so another question, next question is, how does the use of depth of anesthesia monitors and TEVA pumps equate with the use of desflurane vaporizers? So I suspect that's a question about the hardware, So the actual physical box of the depth of anesthesia monitor and the electronics in the TIVA pump being used, how does that weigh up against the use of a desiflurane vaporizer? Does anybody have an opinion on that?
I think questions like that are very difficult. It's a bit like the apples and pears thing again, and I think perhaps some of the kind of these comparison studies, so the life cycle analysis, would take into account the wider picture and some won't. So I think that's tricky. I don't know what you think, Lucy.
Yeah, I would agree. I think when we're looking at life cycle analyses, it's really important to look at the boundaries, and different studies will include different things, and the people who are trying to sell you their gear will always give you the best numbers possible. Maybe I'm a cynic, but I also think that it's a lot of things when we're comparing, particularly talking about drug use, we're talking about, for drugs, active pharmaceutical agents, and our drugs contain lots of other things that are not active pharmaceutical agents, which makes it difficult to compare. And when it comes to hardware, it's really difficult because also you need to take into account how many do you need, how often does it need replacing, and comparing unit for unit is not necessarily helpful. We probably need to look at use for use. And a lot of the data around this stuff is proprietary. So how you make a drug, how you make a vaporizer, we can't know because the companies won't tell us, which makes making decisions like that really murky. And so it's not trying to be a cop-out to say that's really difficult, but the truth is I don't think we have enough information to really make that decision ourselves.
Okay, thank you. So somebody's whispered in my ear, thank you very much. There's an article in the February environmental theme edition of Anaesthesia News giving some information about the environmental impact of CMAC and Macintosh blades. So thanks for that, my little elf. So next question is, how do we marry the association guidance on infection control advocating single use with the sustainability agenda?
I think we should change guidance. Again, that maybe that's a bit radical. I think that we need to be evidence-based practitioners. That's really important. And where the evidence is strong, then that's appropriate. But when we're talking about patient safety, we should not only be talking about the patient in front of us, we should also be talking about all of the patients and all of the populations, and the environmental harms that we do also have impact on others. I think that there is a lot of things that we could be looking at. For example, things like using the need for sterile gowns for single shot spinal anaesthesia, for example, is something that is ripe for review. And I think that that you can raise your concerns and take them forward. Frank's on the Association Environmental Committee, and so maybe he should raise it there for us. And similarly, myself at the college, I think that where it doesn't feel like our practice and our guidance aligns with our current evidence and understanding, we shouldn't be afraid of saying, okay, we need to do it differently now.
And things change, and that's okay, and we need to embrace that and learn from it and go, okay, maybe that was wrong, let's look at what else we can do, rather than be defensive about it.
Okay, thank you. Next question is, if we stop using desiflurane and stop using nitrous oxide and we limit ourselves to a very few number of agents and techniques, are we de-skilling, and are we diluting the professionalism of our roles?
I think, in my opinion, we would only be de-skilling if we were providing if they were kind of equivocal services, or if they were both a good anaesthetic, I guess, in our hands, in us who have never used those things. I don't know. That wasn't very eloquent. Lucy, be more eloquent.
What I would say is that I don't know how to use halothane. and I don't feel that that makes me an unsafe anaesthetist. And I'm absolutely certain that when I'm nearing my retirement, that there will be practices that I'm less familiar with coming through. I would reiterate what Esme said, change does happen, and change is hard and change is scary, and people don't like to change. None of us here today like to change, but sometimes it's necessary, and simply because the way something was done before doesn't mean that we're going to be de-skilled. I can't see a situation I'm going to find myself in where someone says you must give a nitrous desflurane anaesthetic. I can't see it, because it's partly because, particularly with desflurane, it's expensive. So even in a resource poor area, if I found myself working there, I'm unlikely to be presented with that option. And I think that I'd be more concerned about the fact that our consultant colleagues don't feel confident using TIVA, because there are clinical scenarios where you really might have to use TIVA for patients who can't have volatile anaesthetic. And I think that's actually a more important question.
Okay, thank you. I'm going to move on for fear of becoming too inflammatory. So in this world where a company rep will turn up in the department and buy us sandwiches and tell us that their new device is a new super duper whizzy thing that's going to massively reduce the environmental impact of our practice. Can you give us any tips on how we can be sure or be confident that we're not being greenwashed?
I think we're all intelligent individuals, and we do this every day with things that we buy or things that we come across or things that we see. We take into account the information, not only that we're being sold, but also take into account the things we know around us. What does that fit with what we know? Is it actually going to be that good? Because if it sounds like it's going to save the world, it's probably not. So we just need, the same as if we were looking at a paper and critically reviewing it, we need to have our eyes open and not just listen to what is being told to us.
And I think there's a role for asking challenging questions. You know, thinking about what is it that you want to know about this. So asking about life cycle analysis, you've said that this thing is going to save carbon equivalents or save carbon dioxide emissions through this mechanism, but how much carbon does it take to make your item? And can they tell you that? And I think for me, one of the ways I make a decision is based on transparency. So what is that company telling me, and how easily can I find out information that's important to me, like what's the overall balance of this, or what happens to your waste once you at the end of the life cycle of whatever the product is. And coming back to the triple bottom line, so what benefit is this going to have for patients? And because a lot of things that people come with do sound brilliant for patients, you know, this can reduce your risk of whatever by X%, but is that clinically significant versus is that statistically significant? And I agree with Esme, just having a critical eye on people who are trying to sell you things is really important.
Okay, thank you very much. There's one more comment, which is probably more homework for myself and Lucy, but it says that the Australia and New Zealand College of Anaesthetists classifies laryngoscope handles as a non-critical and as recommendations on how to disinfect them. And would it be an option for the association or the Royal College to come up with something similar? I'm not going to ask you to answer that now, but I think that it's something we can have a think about and maybe take back to our respective committees in the coming weeks and months. Okay, so I'm going to draw this evening's webinar to a close now. Thank you very much to all the speakers and to all the audience for attending. Thank you for your great questions and insightful answers. Thank you to the Association of Anaesthetists for hosting. An email with instructions on how to access the recording will be sent out to you probably tomorrow. And we would be extremely grateful if you could complete the delegate evaluation survey, which you'll receive by email shortly. It's only by getting feedback and suggestions from the delegates that we can put this program together and continue to host them. And for more upcoming online education, please do visit the association website, where there's information about upcoming webinars and other educational opportunities. And thank you very much all for attending. Have a great evening.
Thank you.
Thank you.